So I think I have a chance to talk for almost 1 hour, but I'm trying to get it sooner because we have lunch. So I'm quite excited to go for the lunch right away. So I will try to wrap things as soon as I can. But I think this is a very important topic that I want just to give you an example of research that is based on clinical practice. This is what we call it translational research. And this is a new approach that I concluded in my lab and in my research activity to try to come up with what we call it, the personalized medicine based on different factors, different days and different doses, based on different disease states, and maybe some genetic factors also. In this case, I'm an antibiotics person, so I'm an infectious disease person. So when we talk about pharmacogenomics, I'm not dealing with the CYP and the metabolism. I'm dealing with the genes in the bacteria itself, because this is a target. So I'm more interested to identify the genes that are responsible for resistance of these organisms and try to find a way to overcome this resistance by modulating and changing the dosing. So my ultimate goal is to make sure that I achieve the maximum dose based on what I have here and try to make sure that I achieve this dose by simply maximizing the therapy. Let me see, this is the right one. I usually do that when I have some research presentation. I start by a case study just to give you the stage, set the stage for that, and then I give you the rationale for that research. Then I will give you the real beef in that research, which is basically my specialty, which is PK/PD, pharmacokinetic pharmacodynamics, and in my case, it's more of antibiotics PK/PD. And then I give you example of my approach or our approach that we used to have it for the last 10 or 15 years now, together with my colleagues who started this model. And I can't forget, Dr. George Dursano, George Zanel, all of these guys are great, who helped me to learn, and all of us tried to do something in the field of PK/PD, achieving the goal of maximizing the dose of antibiotics. This is part of the fight or the war against bacterial resistance. Let me start by a case here, and this is classic. I do that all the time. FT, whatever the name is a 25 years old male with 2 months history of cough and increased sputum production. He presents to the outpatient clinic with fever, new chest pain. When he coughs, he has shortness of breath, blood-tinged sputum. He has history of bronchial asthma in childhood. He has sickle cell anemia that required splenectomy. When I say splenectomy, this means what? That we remove the source of production of the immune system. So this patient is almost immune compromised. So this is one factor here. The medication history is basically therapy for the, let me see if I have pointer here. No? Kills it. Yeah, it works. So this patient have history of medication for asthma, salbutamol inhaler to pass QID, and he has also beclomethasone inhaler. These are classic for asthma therapy. And he receives oxycodone and aspirin to tablets Q6 hours PRN. This is for the serious, severe pain that sickled patients are having or going through. But also what's important here that this patient had history of ciprofloxacin, 500 milligram Q8 hours for 10 days, 1 month ago. We are not quite sure what was the reason for that, but somewhere, somehow, within last months, he went to a clinic, and I think the physician, he had some whatever infection, and it was maybe needed to have ciprofloxacin. And my wild guess that this was simple, pulmonary or lung infection, that it might have been even flu or maybe simple laryngitis, whatever. But the reason here is simply to mention that this was a history, which is very important here. That's why I highlighted that this was a ciprofloxacin, a fluoroquinolone received 1 month before for some reason. This patient was diagnosed with community-acquired pneumonia, CAP, that was a PSI score, severity score of 3. This means that this is mild to severe pneumonia. For sure, he was admitted to the internal medicine ward, and he received the classic therapy at that time, levofloxacin 500 milligram Q 24 hours. This is classic case, patient who is admitted with pneumonia. We gave him levofloxacin, and this is the used gold standard therapy right now. Then a culture was made, and it was found to be Streptococcus pneumoniae. He has MIC initially was 2 microgram per ml that had PAR-C gene. Then within therapy, within few days in therapy, this MIC jumped from 2 to 16. So now resistance began to be more evident here, and now we have 2 genes responsible for the resistance. This patient received medication, had Streptococcus pneumoniae. However, this should be a successful story, but there is no improvement. Patient got meningitis, developed meningitis on day 4 and died. So this is a story of a patient who died. And this is a really a dire outcome that we don't expect, but there was something wrong here. Because this patient supposedly should not die, because he is young, 25 years old. Yes, he's immunocompromised a little bit, but he is healthy. He had come here with a simple infection, community-acquired pneumonia that can easily be treated by levofloxacin, and this therapy will stay for last for maybe 3, 4, 5 days, and send home to continue for maybe 2 weeks, and that's it. And he should be recovered. But this is a patient who died. So there is something wrong here. And as clinical pharmacists, as clinicians, as scientists, we should not stop here and say, okay, he died. Who cares? Let's just see what's going to happen. Our duty is just to go back and say, what happened here? What was the story here? And begin to learn from that and identify the problem. What was missing here? You know, this guy received medication that's adequate for therapy for a simple treatable disease, and he's a young, healthy, patient. So what will happen should be a successful outcome, but he died. So our duty and our values dictate that we have to go back and stay and pause and say, there is something wrong. What happened? We have to learn from that. So, and this is also as a scientist, as a translational scientist, I have to identify the problems in the clinic here and learn from this problem and begin to identify the reason, find a solution, and then go back and try to help saving lives after that. So to do that, we had to go back to the basics. We have to go back to the textbook and say, what I learned from this story here. I'll go back to the basics. I'll say, let's just go back to that day 1 when someone in the lab discovered a molecule which is antibiotic and claimed that this is all going to be effective in treating or killing bacteria. And we gave it to the patient, and the patient actually recovered. But does this happen all the time? No. Most of the time, we give the ideal molecule that was identified to be a good antibiotic, and you give it to the lab, and the lab will show at the lab level that this is really effective antibiotic. It kills all the bacteria. I can see it under microscope. I give to the patient. It doesn't work. It happens every day. We see that every day. So this is a story that we have to stop and say, hey, what's happening here? Let's learn from our experience and background. Let's think about it. What are the causes of this antibiotic failure? Tons of causes. So I'm not going to go over all of these causes, including maybe compliance, all of the things, but I will focus here as a clinical pharmacologist or clinical pharmacist in what's really important for me that I can learn from that. I'll focus on the pharmacological failure and also focus on the microorganism itself. These are the 2 components that as a pharmacist I'm really concerned. What will be my enemy, the bug? Is it a dangerous enemy? Is it resistant? And also what will be the effect of my therapy, the pharmacological effect? So these are the 2 components that I'm really interested to look at. So I look at the pharmacological effect and see maybe the drug given in an insufficient dose, or there was no real good diagnosis, or there might be something wrong in the pharmacodynamic parameters. There might be something that led to a suboptimal therapy. At the same time, there might be something wrong with the pathogen itself. It might be resistance that developed during treatment. I have to understand that. Or maybe the antimicrobial is giving there, but it doesn't have good coverage for the bacteria, and maybe there might be some bacterial persistence. So these are the factors that I have to highlight and look under the microscope and try to understand what's happening here. So I go back to the microbiological evaluation. What happened is that there is something wrong here. What happened is that I receive information based on a static model. Let's put it this way. So in the lab, what they do, they have all of these antimicrobials, plates, the plate with the bacteria there, and then we have all of these desks for different antibiotics, and then see what's the sensitivity, and then try to identify the MIC and the breakpoints. This is typical microbiology lab, maybe microdilution, where I can see the turbidity, and then I try to define the MIC. This is what the lab does all the time, till now. But tell me, do you think the human body functions this way? Are we static thing? We are dynamic. Everything is circulating. We have dynamic process. There is blood circulating all the time. You give the drug, it goes into the absorption, and then you reach the peak, and then the elimination. It's a process that goes to a dynamic process. And also, there are different factors. If I get a drug, antibiotic, my friend who is 25 years old get the same antibiotic, is it going to be the same effect? No, because I have different physiology. I have different kinetics. So this is different stories. It's not a plate with an antibiotic with a bug and try to see what will be the outcome. So what I'm arguing against right now is that what we are doing here is absolutely wrong. It doesn't represent the real clinical setting. So our job as clinicians or scientists in this case is try to model what's happening in the real setting. So we can come up with outcome that's really representing what's happening in the real human body and in the clinic. And another point to argue against that is simply when somebody say that this is basically the effect, the drug given over time, the concentration is here, but then you talk about MIC from the lab. Where is this MIC? Is it here at the peak? Is it here at the trough? Is it here at the middle? Who knows? So that's why this is really a solid argument against what we are talking about initially as a static model. This is garbage. We should not rely on that. We have to rely on more of dynamic modeling of what's happening. And this is what I'm going to build the case right now. And that's what we tried to do that maybe 15 years ago. I joined this group maybe after 5 years of their work, and I began to work with them. And the idea here is simply that we have to combine the pharmacokinetics and the pharmacodynamics of the antibiotic both together into consideration. We have to get them, I call it marriage, where we combine all of the effect of the drug on the human from the kinetics point of view as absorption, distribution, metabolism, excretion, again, together with the pharmacodynamics, which is basically the effect of the antibiotic on the bacteria, like talk about potency, killing, persistent effect, and immune factor system that will have a component in this type of effect. What we do here is that we have to include and consider and combine, I call it getting a marriage certificate between both two factors here to aim toward bacterial eradication. So my theory here, or what we propose here, is that we have to put into consideration the kinetics and the dynamics, both of them, in making our decisions for dosing and optimizing the therapy for these patients in antibiotics. I'm talking about antibiotics here. That's why when we have this classic, concentration versus time, curve, the bell-shaped curve, which is very famous, when you have the drug given and then you go through the absorption, and then you have the distribution, and then you have the Cmax or the maximum concentration, and then we go through the elimination phase where you have the drug concentration decline in the body, you give the second dose, the third dose, and so on, and this is where we have the kinetic parameters, or the kinetic parameters, where you have the Cmax and Cmin, you have area under the curve, we have a plot for the sigmoid, a structure there that you can have the elimination rate constant, and you go ahead and calculate all the parameters for the VD, volume distribution, all of these things. This is kinetics. But as I said, it's not only kinetics. We added dynamics into it. So now we have a new way of looking at the drug effect here. When we have the kinetics, but then add to it the dynamics, which is typically, in the case of antibiotics, the MIC, the minimum antibiotic concentration. So you have to consider the MIC for this bacteria. It might be 1, it might be 2, it might be 10, it might be 0.01, whatever. But I have to consider the MIC in my calculations. I have to consider it in my predictions of outcome. So here we put the MIC. Now we came up with some new principles that dictate or which shows us exactly what are the most important parameters that will govern the antimicrobial effect. So we came up with new things here. We call it Cmax divided by MIC. This is one factor. AUC, which is area under the curve, divided by the MIC, another factor. Then we come here with the time above the MIC. So this is the time, let's say from hour 1 to hour 12 or hour 13, the time the drug spends above the MIC. 13 minus 1 is 12. So the drug spends, let's say, 12 hours, 4 hours, 20 hours, whatever. But these are factors that we have to consider to make sure that these are going to govern the outcome of our therapy. So let me give you an example here. And by the way, this is a work of great guys, Alan Forrest, talk about Mike Rybeck. All of these guys spend years and years in the lab and working. I did some part of this work also in my lab when I was in Canada, that we did things with Streptococcus pneumoniae, and this was against the macrolide. But in this case, I did some work with the fluoroquinolones also. Let me just focus as an example. But this example can be applied in everything. So when you say fluoroquinolone, you can put here, let's say, azithromycin. You can say penicillin. You can say cephalosporin. This is one factor. So sky is the limit. Research is unlimited here. Versus Streptococcus pneumoniae. It can be MRSA. It can be Acinetobacter. It can be Pseudomonas aeruginosa. You name it. So the variables, you can play with it. You can change it. But each one is a story by itself. So let's talk about a story here of, and especially this is related to our patient. So I chose a patient who has Streptococcus pneumoniae, remember? And this is a community-acquired pneumonia infection. And this patient was given fluoroquinolone. So I'm trying to solve the issue here. So luckily, those guys like Zanel, Andy and Greg Peterson and Alan Forrest and Thomas Lodis, all of these guys did lots of work. And still, you talk about Kuti, you talk about David Nicolo, all of these guys are still working. We are still working in our labs to try to come up with different scenarios and make sure that we are doing a good job. So at the end of the day, at least especially, I know that it was mainly Alan Forrest, we call him the bear, who came up with some real nice, and I think Shentag at the same time, came up with some real numbers. And this is cool. When you have numbers, you say, yes, if achieve this target, you can kill the bacteria. Don't achieve it, no way. So came up with numbers here after lots of experiments. I'm going to show sometime maybe in the next lecture how they did that. They had lots of animal models. We developed lots of in vitro models to come up with real numbers that will say, hey, when you have a patient who has nosocomial pneumonia, and you find that the fluoroquinolone area under the curve divided by MIC, whatever the number is, if you divide that and you get a number of 125 or above, you are successful. You are going to achieve bacterial eradication. If you achieve AUC over the MIC of, let's say, 90, it's not enough. What this means? This means that the AUC area under the curve, the amount of the drug that was given is not enough. So what's the message here? Increase the dose. This tells me that the dose is not good enough, increase the dose. Or the other side, if the MIC is 1, that's fine. But if the MIC is 2 or 3 or 4 or 5, this means that the outcome will be lower. So in this case, the more resistant the bug, the more difficult to treat. So in this case, in the case of fluoroquinolone, you have to increase the dose to achieve, in case of nosocomial pneumonia, AUC over the MIC of 125. When I say AUC here, I have to talk about the free drug, because the free drug is the active drug. So I have to include also factor for the protein binding here. So I multiply by 0.07, whatever the factor here. This is in case of nosocomial pneumonia. In case of our patient community-acquired pneumonia, they found that area under the curve of the free drug, when you divide by the MIC, your target, we call it target attainment, is 30 or above. So this is your target here. As a clinical pharmacologist or clinical pharmacist, you have now tools to calculate and predict the outcome. Let me give this drug. Let me calculate the AUC for the free drug. Let me look at the lab and tell me what the MIC is. Let me calculate the AUC over the MIC. Is it 30 or above? Yes. Bingo. I know that this patient will be treated. But if AUC over the MIC is less than 30, this patient is going to die. Period. So this is what we call it prediction based on numbers and principles, not just guessing. And this is what's happening in the clinical setting. Everything, especially in antibiotics, is a guessing. Let me give him this drug. Oh, it didn't work. All right, just increase the dose. How much? I don't know. Let's increase it a little bit up. Or reduce it a little bit. Or maybe give another drug. Oh, let's just stop it and give another drug. Based on what, my friend? Nothing. It's just, oh, this is my experience. No, this is garbage. I need facts. I need numbers. That's why when we have our rotation, we calculate that and say, hey, my numbers, my calculations show me that your dose is not right. You need to increase the dose or change the medication. How did you come with that? My friend, these are the numbers, these are the facts, this is my calculation, and now I tell you that this is going to work if you adjust the dose based on what I tell you. So let's just go back to the fluoroquinolone and to our patient. Now we are done with the pharmacological part here. Let's go to the other side of the story. We said that the two components here are the kinetics and the dynamics. Now we are done with the kinetics. What about the dynamics? Because the dynamics is basically MIC, which is basically dependent on the bacterial resistance. If the MIC is 1 or higher, this is more resistant. Let me look at that and understand what's happening here. And this is the other side of the story. My enemy is a smart guy and very clever and actually changing the pattern of resistance every moment. And dependent on various factors can sneak in and try to find a way to beat my therapy here. So I have to be careful. So to do that, I have to understand what this bug is doing here, what the mechanism of resistance. To get the mechanism of resistance, I have to learn first what the mechanism of action of that drug that the bug began to develop resistance against. So let me just understand that. Let me go back to my literature and say, okay, how this fluoroquinolone works. They work mainly on the topoisomerases. It binds to those topoisomerases, and you have DNA gyrase, which is topoisomerase 3 or topoisomerase 4, and the fluoroquinolones work by just modifying these topoisomerases that are very important to unwind the DNA. And by the way, this topoisomerase 4 works by action of the gene or stimulation of the gene PAR-C or PAR-E. In our case here, it was found that PAR-C is the more active. This is the one that I have to worry about. For the DNA, topoisomerase 3, which is the DNA gyrase, they have gyre and gyre-B. Gyre A is the one that's more active. So this is the guy that I have to worry about. So here, the genes that are on the DNA or for these topoisomerases are responsible for encoding for the topoisomerase and production of topoisomerase are the PAR-C and the gyre. So I'm a bug. I understand that the topoisomerases are the ones that are important for my life. So what they do, the antibiotic, what does is simply comes here and work on this PAR-C and gyre and the topoisomerases and try to modify it and doesn't get it. So now I stop the replication of the DNA. Now I can kill the bacteria. As a bug, what I do? Let me fool these guys. The fluoroquinolone comes here and try to destroy my topoisomerases by working on the PAR-C and the gyre. So what I will do? I will change the gene structure here. So I'll try to express the PAR-C and work on the gyre and try to make it more prominent. So the fluoroquinolone comes here, you don't find it. They find modified genes. And the antibiotic comes here, find nothing to treat or nothing to kill or modify. That's why the antibiotic doesn't work. You just give this antibiotic as water. Doesn't work. The target is not there. They fool the target. And this is a very smart way the bacteria do all the time. I'm just giving you an example of Streptococcus pneumoniae when you treat with the fluoroquinolone. There is lots of other mechanisms like the MRSA, like Pseudomonas. They have tons of things. But our job is to identify this mechanism of resistance and study it. And then learn from this mechanism of resistance and begin to try to tailor our therapy to be smarter, hopefully, than the bacteria itself. So this is exactly what happened. The resistance here, because there is now the bacteria begin to modify the binding sites, the gyre and pyrc. So the antibiotic comes here, find nothing. It's different, it's modified, so no effect. The other mechanism is simply by the bacteria. The antibiotic comes to the cell of the bacteria here, but then there is a pump, efflux pump, PMRA gene based, that will simply sweep or clean the antibiotic out, push it out. And this is the other mechanism, but by the way, this mechanism is not that effective. So mainly target modification is the key for resistance in Streptococcus pneumoniae versus fluoroquinolones. So this is resistance that's happening. Another characteristic of this resistance is very interesting. We have to study it. It is rapid during therapy. So you can give the antibiotic, the fluoroquinolone, to a bacteria or a Streptococcus pneumoniae with MRSA of 1, which is not resistance per se. But during therapy, it can switch and change the genes and make it modified, so the bacteria will have different genes to work on for the fluoroquinolones. Now the fluoroquinolone come and find no target. The bacteria begin to have more resistance. So the MIC can jump from 1 to 4 to 16 during therapy, which is far more dangerous than what we expect. You can start with a real, non-resistant bacteria, but then during therapy, it changed to be resistant or development of resistance during therapy itself. The other problem here is that it's spontaneous. There is no extra genes to get outside from other bacteria. It is there. The genes are there, just modifying the genes. It's a spontaneous process. And also what's more important is that it is stepwise accumulation, i.e., it starts first by modifying one gene, the PARC. So the MIC jumps from 1 to 2 or 3 or 4. This is called low-level resistance, still can be treated by fluoroquinolones. But then, during therapy, if you still keep giving the fluoroquinolone, this resistance jumps to the second step or next step, which is PARC gyre. You have both genes are modified. Now MIC jumps from 1, 2 to 16, 32 or more than that. This is high level of resistance. No way fluoroquinolone will work here. So this is too much for the fluoroquinolone to work on, unless we change the dose here. But this is what happens. It's a two-step, PARC and then gyre. So now we understand what happens for the drug in the body, the kinetics. Now we understand what happens for the bacteria, for the resistance. Now let's just get some lessons and see what we can do to identify that, and then what we can do to overcome that. So we thought about it, and we said, okay, our first step is to identify bacteria that has first step mutations. Because you see, ciprofloxacin or fluoroquinolones are in the air, in the tap water. You go to a physician just for simple laryngitis or simple flu or simple symptoms, upper respiratory tract infection, and just gave you ciprofloxacin or gave you a fluoroquinolone. And this is normal practice or abuse of therapy or prescription pattern all over the world. This is one thing. Here's the point. When you give a patient ciprofloxacin for something else, what happens is that the normal flora, the normal Streptococcus pneumoniae in the throat is affected. So it finds that there is ciprofloxacin there. Oh, wow, let me change into a resistant organism. So they change into a first step PARC level of resistance. And our hypothesis was simply that it is there, but we don't know it. It is there. but we don't have any idea what's happening here. So our job is to detect the first step mutation and see how things are working there. The second step is just to try to find a way to kill this first step mutation before it is too late. Because if it goes to the second step, MIC is very high, it will be very difficult. So our way of preventing is to identify the first step mutants and try to wipe it and get rid of it. So this was our approach. How did we do that? At that time, I was working in Canada with Roger Zanel at that time, and we noted that levofloxacin, reported to be successful in the lab, but then when you give to the patient, there is still no good outcome. So the question here is that those susceptible organisms, are they really susceptible? We receive from the lab, SIR. It's susceptible, it's S. But is it really susceptible? We question that, because the way they test it is not really adequate. This is what we need to go at the gene level and identify, because it might look susceptible, but it have a PAR C first step mutation. This was our hypothesis. So let's do that. So how we did that? We still run that till now. We run North American surveillance study. So we collect isolates from all over North America, and now we are expanding that to different parts of the world right now. And there's lots of studies like that, where we collect all of streptococcus from the hospitals that are isolated from patients with community-acquired pneumonia, for example. And we get all of this pool of bacteria, and then identify the MIC, and then see what the MIC there. But what's more, we just do genotyping for those resistant ones. So if we find one which is higher than what we believe is normal MIC, we begin to identify the gene there, identify the PAR C and the gyre and all of these things. So we do some genetic identification. Beyond the MIC, we just identify the PAR C and gyre mutants in our isolates. And here's what happened, believe it or not. We discovered that out of thousands of isolates that are tagged as susceptible to fluoroquinolones, we discovered that at least 70% of those susceptible isolates, they carry PAR C. Duh. And then the rest of them, maybe 3% gyre, and then 3 maybe PAR C gyre. But what's important here is that those isolates around us that has, simple susceptibility, which is simply susceptible, are actually having PAR C. This is very important and very dangerous. Somebody tell me why. Because this patient who has this PAR C isolate, if he or she happens to receive a fluoroquinolone, what will happen? It will jump to the second stage or second step of resistance is going to be PAR C gyre. PAR C gyre is a high-level resistance. MIC will be 16, 20, 33, whatever. This is really a very difficult situation. So this is very important. That's why we called it the tip of iceberg. There is something there, but we are not quite sure that there is really a big thing there. There is something that we have to worry. This is really a major problem. This is major public health issue here. So what to do? We detected the first step mutants and we identified the iceberg. Then the second step is to try to identify the doses that can kill bacteria with first step mutations. And maybe hopefully the second step also, if we can approach that. And this is what I call it clinical simulation and pharmacodynamic approach. How we do that? We cannot test it or test drive it on patients. We cannot bring patients and infect them with PAR C gyre or organism and then give them medication and try to see who's going to die, who's going to survive. This is not going to happen. And also we cannot, test it, in different even animals. So we thought that we do what we call PKPD, clinical simulation. Let's just do simulation and mathematical modeling to identify the scenarios that will be successful to be able to eradicate this bacteria. So this is what we did. We built pharmacokinetic population model, And this can be built either from running different clinical studies, simple on healthy volunteers to identify the kinetics of fluoroquinolone in patients or in humans or in healthy volunteers. The key thing is just we identify the kinetic parameters. But we build a kinetic model, population model, that will represent a big population. So we don't say that we have 5 healthy volunteers, we give them drug A, and then we measure the drug, and then we found that the PK is whatever, the Vmax or the Tmax or VD or the AUC is so and so. This represents 5 patients. It doesn't represent the whole population. So what we do is in this case, what we did, we collected different data from different studies all over the world. Those guys who published, kinetics of fluoroquinolone, let's say levofloxacin, in patients, whatever. Let's just get all the data from them and put it into a model. We call it pharmacometrics or pharmacokinetic population model that basically represent the overall population. You talk about the whole population, and you can make simulation to make it represent thousands of patients. This is more reliable, more representative. So I can say that the VD, volume distribution of fluoroquinolone or levofloxacin, and those patients who are 20 to 50 years old is that number. And I'm quite sure that my number is accurate because it represents huge bell-shaped data. So it is really all over the place. The same thing I do it for the MIC. We got all the MIC from those pathogens, identified the PAR-C, and then we calculated all of them. You talk about at least hundreds of MICs. Is it enough? No. What we did, we have the kinetics distribution of data, and then we have the dynamics, which is the MIC distribution of data, and then we got them married. That's what I said, PK and PD marriage. We added both of them to build that model, and then we ran what we call it Monte Carlo simulation. It's a Markov model. It's simply iteration. So it will combine both data here and then begin to build what we call it what-if scenario based on real kinetics data, based on real dynamics data. And that's exactly our model. That's what we call it clinical simulation. So our hypothesis is simply that those drugs or fluoroquinolones that have higher AUC, you remember that the factor there is AUC above the MIC, so the higher the area under the curve, the higher drug exposure, the better effect to kill these bacteria. And that's what we did. So we modeled AUC distribution of Cipro, Levo, Gatti, Garinoxacin, Moxifloxacin, Gemifloxacin. At that time, these are the most important ones. Even some of them were research-wise, but we want to have the whole spectrum there. And then we modeled different treatment scenarios, modeled different dosage. So Cipro, if it's given 250 once daily, 500 once daily, BD twice daily, 500 BD, 750 BD. Levo, what are the doses? Even I put here 1,000. It's not really clinically relevant, but I thought that let me just see what if we give 1,000. It's not clinically relevant, but let me just, because this is a hypothesis. So I ran from 500, 750 to 1,000. Gatti, I just modeled 400 for all of them, which is the clinical dosage for that. So we modeled what if scenario. If we give the dose of levofloxacin 500 milligram, what will be the area under the curve from my PK model? And if I give a dose of Moxi 400 milligram, what will be the AUC for my model here? At the same time, I have all the Streptococcus pneumoniae genetics distribution there. I combined both of them into a Markov model. So I got all of these AUC distribution versus MIC distribution into a Monte Carlo Markov modeling there, and then the outcome will tell me what's going to happen. If I find that AUC over the MIC, as I said for the fluoroquinolone, is more than 30 or above, this means that my therapy in that dose is going to be effective. If it's less, it's not going to be effective. So now I have numbers that I can work with. So what I did with this Monte Carlo is we simulated more than almost 10,000 patients. So we have maybe 1,000 patients both sides, but we make simulation, because this is iteration process. So we have simulation of 10,000 patients. The more the simulation, the more powerful the outcome here. And that's what we did. And then we calculated the probability of achieving our target here. This is what we got. Okay, we still have time. Look at that. Now we found the following. If you give the fluoroquinolone versus Streptococcus pneumoniae that already harbor or has PAR-C gene, if you give Cipro 250 BD, it cannot achieve 30, the number, the magic number that we call here. This means what? Failure. Cipro will not ever work on Streptococcus pneumoniae with PAR-C. I tried 4 here just to make sure that this is, for the research point of view. Don't worry about that. Let's just focus on the theory, because this is what's proven here. So we found that 250, 500, 750 milligram, which is the maximum dose for ciprofloxacin twice daily, will not achieve the magic number here. In fact, it achieves 0. What's the message here? Ciprofloxacin is a poor drug, a garbage drug to treat Streptococcus pneumoniae, especially if it has some sort of resistance. So the take-home message here to any clinician, never, ever, ever use Cipro for any upper respiratory tract infection that especially includes Streptococcus pneumoniae. This is number one message. We proved it. We didn't guess. We didn't say, oh, this is from our experience. We now show them the data. It is 0. This is failure. It's not going to work. Now, let's look at let's look at galloxacin and Moxi and Gati. These are good drugs because it shows that when we give them in the therapeutic doses, and remember here that I made simulations for the doses and the concentrations in the serum and also in the epithelial lining fluid, because this is where the respiratory tract infection are there. They are mainly not inside the cells. They are in the ELF, which is the fluid around the cells. This is where the bacteria are almost there, and this is where the drug should go and act. So I simulated both of them. Let's say the infection is in the blood, or infection is in the lung, but in the ELF. I simulated both scenarios. And I found that for galinoxacin in serum or ELF, GEMI, or Moxi, or even Gati, all of these drugs are excellent drugs that can be used in these normal clinical doses, achieve 97% or more than that probability of killing this bacteria. So the take-home message here, if you want to kill this bacteria, use one of these drugs. Let's look at our friend here, levo, which is the standard therapy. When we have levo given at 500 milligram once daily, you have almost 50% probability of achieving the outcome. This is good enough? No. And even in the ELF, it's almost 60%. This is good enough? Nope. This means what? Levofloxacin, 500 milligram, is not going to work on the bacteria that's resistant, which is PAR-C resistant. Remember our patient? Our friend who died? He received levofloxacin, 500 milligram, and he had already exposure to Cipro for some reason. This means that what? This tells us what? That this patient had Streptococcus pneumoniae exposed to Cipro, developed PAR-C, and then when you give the levofloxacin in 500 milligram, this is a dire outcome. This patient was killed, not died. Because of ignorance, if somebody had looked at the ciprofloxacin exposure before, within last months, if there was a smart clinical pharmacist or clinical pharmacologist who understand all of the things that we talked about, he could have picked that and say, hey, stop here. This guy had ciprofloxacin before. Most probably has PAR-C. If we give him or give her 500 milligram, it will give me 50% probability of outcome. This is not enough because there is 50% probability of killing this patient. And that's what happened. Now, if we increase the dose to 750, you talk about 80 to 86, which is okay, but it's not good enough. I would go for 90 or above. So in this case, we say that levofloxacin, does not achieve the outcome that will target a team that will kill these bacteria. If a patient comes with infection, Streptococcus pneumoniae, with previous exposure to fluoroquinolone, I will not give him levo or Cipro, for sure. For sure. For the levo, still wishy-washy, but it depends who are going to treat. If you are treating your mother-in-law, that's fine. If it's your mother, no way. You got my point? So it is, my mother was just a wonderful woman, I'm just kidding, you know. I tried just the 1,000 for the fun of it, but there is no clinical relevance here for that 1,000. So the take-home message is clear. We have now numbers that tells us that this is the dose that we need to give in treatment of this type of resistance. Let's talk now about the second level of resistance. If it happened, this is what happened to our patient. Remember that he receives Cipro and then he receives Levo. Within the therapy, the MIC jumped from 4 to 16. What does this mean? It tells me that this patient started by PAR-C resistance. During therapy, developed the second level of resistance, PAR-C gyre, MIC 16. Let's see how can it work here. Nothing will work here. So if we give this patient whatever, fluoroquinolone, he's going to die because nothing is work. Maybe Moxie in ELF maybe has 87, but again, this is not convincing me that I give him. So in this case, the second message here, if you have a patient who has exposure to a fluoroquinolone, you should not start any fluoroquinolone. Or maybe you can start a fluoroquinolone with another drug. Now you have to use combination therapy. So the message is here, Cipro, garbage. Levo, normal dose is not effective. Maybe 750 is okay, but it's not good enough for me. I don't give it to my mom. PAR-C, the Moxie, Gami, Gati are okay, are good for me. But it depends if it's still the first level. But if it will go to the second level, PAR-C gyre, no way, no ciprofloxacin, no Moxie, no Gati, nothing. And even to be more safe, it's advised, and now these are the guidelines built on this research. The guidelines now is that if you have to check for patient records and ask the patient, what did you receive in the last month? If someone tells you that this is a fluoroquinolone, don't start any fluoroquinolone therapy. This is going to be a real dangerous situation. So this is another message here. In this case, if you want to start fluoroquinolone, you at least have to give some sort of combination therapy. This work actually was done with a group of my real colleagues in the lab and in the simulation stuff, and these are the great guys. These are my friends and my colleagues who work with me in my lab, and I call them the winning team, and they are great guys. Thank you again.
Well, do we have any questions? Well, no questions. Now we have a lunch break.
There's one question.
Oh, one question. Well, okay.
Thank you for your brief introduction, brief lecture. Just as per our national antibiotic guidelines in Malaysia, currently, which we shifted from this, all the amoxicillin, ampicillin to community acute pneumonia for macrolides. Is it okay? We need to revise the things which fluoroquinolone's dosage increase, or we can continue with these macrolides for this community acute pneumonia?
You know, you talk about macrolide shifting because you are covering also for the atypical.
Because even I have the certain controversial with macrolides, but even this is given in national antibiotic guidelines, which we can't cross over the conditions which we practice in this situation of our government. That's only I want to ask. How we can revise this?
Simply by looking at the data and the literature. And this type of publications are very helpful. So the guidelines are built based on meeting of the big guys, the big
yes,
brains,
absolutely.
But you look at, you don't just come up with their guideline. You have to look at the literature, what happened on the real floor there. So for, let's say, for community-acquired pneumonia, not treated in the hospital, let's say in the community, simply you can have the macrolide or simply beta-lactam. If this is a severe case, PSA 3 or 4, now you have to admit this patient. In this case, you have to be more aggressive. And the guideline, the IDSC guideline, is to use fluoroquinolone or even more aggressive therapy there based on the situation there. Or you might even use the macrolide plus a second generation cephalosporin.
Absolutely.
So it depends on setting here. So you have choices here. The message here is that, by the way, fluoroquinolones are still very effective and very good drugs, but Cipro, forget it, for sure.
Yes.
As I showed here, when you talk about the other drugs, that Gatti, Moxie, and all of these things, I showed here that they are still okay. Making sure that this patient did not receive a fluoroquinolone before. So the guidelines, I think it should be in the guidelines that simply you check with the patient. If there is previous exposure to fluoroquinolone, avoid fluoroquinolone. If there is no previous exposure, now we can test drive the Levo or the Moxie, and better Moxie or Gatti and Jemmy. You have to be careful with Levo because you have to give Levo at least high dose. There is nothing called Levo 500 milligram anymore. But based on this research, I did another research also with the acquired pneumonia, and we proved that 500 milligram levofloxacin is not going to work, and now it's not going to work. You have all the guidelines of, even for UTI, is 750, nothing 500 right now. We proved that, and by the way, this guideline based on this type of research that we did. We showed them that it does not work, it won't work, and it proved clinically it's not going to work.
In your clinical, levofloxacin, how many days they treated for your patient, 25 years old patients?
You mean days? How many days?
Yeah.
Simply, the therapy for levofloxacin, if this is a successful therapy, you see in this patient, within 4 days he died. But this was a special situation. But normally, the guidelines for treatment of Levo for CAP took about 3 days. Maybe you start with IV and then send home for the rest of the week, and that's it. Some literature say that even 5 days would be enough to start and finish the therapy for that. Okay?
I doubt. Thank you very much.
You're welcome. Thank you.